Now, as we discussed that why this is a age specific mechanism, why this is the age specific seizure, as we discussed that during the neonatal period, the brain is in their heightened excitability. That's the one main thing, because it have to adjust, they have to learn the new environment. Fine. So due to the learning of the environment, neuron is there in hyperexcitable state, but that's not a fault of neuron again. That's not a fault. It have to be, if it is not in a hyperexcitable state, then patient have the mental retardation. Then one other problem is the ion channels. We know that in the neurons, over the neurons, there are different ion channels. Okay, so some ions comes, they elevate the electrical potential of the neuron, and impulse will travel from one part to the another part. Okay, I'm making it generalized, not a point. Basically, there is a proper node called as the node of Ranvier. So basically, impulse jump from one node to another node to another node, and via this they will going to the synaptic end. Okay, they will trigger, you can say, the synaptic vesicles, and synaptic vesicles will dock over the presynaptic neuron. Fine. And then there will be you can say, the release of neurotransmitters, different neurotransmitter, and that will bind over the postsynaptic neuron. That's the mechanism how our you can say the synaptic transmissions occur. Basically, the impulse will transmit. Got it? So this ion channels is just a protein. No, it's made up of the protein. Okay, ion channels is made up of the protein, like the pentamer ion channel, sodium channel, potassium channel, calcium channel, voltage gated sodium channel, different type of the channels, and these are made up of the proteins. And you know that protein is encoded by the amino acid. The proteins are made up by the amino acid, and amino acid is formed by the expression of different genes. So if there will be a mutation, mark the word, if there is a mutation in these you can say ion channels, then that lead to the further you can say the hyperexcitability in the neuron, end up with the neonatal seizure. Then we discussed that our brain not only behave electrically, it also behave chemically by the help of certain chemicals, and that is called as the neurotransmitter, and other thing is called as the neuropeptide. So one of the neuropeptide called as CRH. Okay, this CRH is like a stress hormone. It exerts the force over the neonate's neuron, and that condition is called as the neonate seizure. These are the, you can say, groundbreaking newer discoveries. These are the latest discoveries. So I thought it's worth to discuss. Fine. Now, yeah, so coming to the pathophysiology, most of the pathophysiology already understood, but just pay the attention here. What is happening? We need an initial trigger for causing this disease. Okay, we need a initial triggers. So initial triggers are what? The causative agents. What are our causative agents? The most, you can say, the favorite one, or you can say the most prominent is a hypoxia, ischemia, encephalopathy. Then we have the different hemorrhages like the intracranial hemorrhage. Okay, different infections like the meningitis, encephalitis, metabolic disturbance. Okay, like the hypoglycemic condition, hypocalcemia, and certain genetic disorder also contribute. These all things lead to the lack of oxygen in the neuron. Okay, or lack of the energy currency. That's called as the glucose. No problem. Fine. And due to this lacking of the things, there is a release of excitatory neurotransmitters like glutamate. Fine. This glutamate, you know that the neurotransmitter will act over where? They can blindly act on anywhere. Fine. They can only specifically act over their receptor. So they are targeting one specific receptor, and that is called as the NMDA receptor. Okay, this NMDA receptors, and there is a increase in the intracellular calcium ion. Now once the intracellular calcium ion increase, fine, then there will be a damage in the cell structure. There's a damage in the cell structure because there's a lot of calcium influx, fine, and that will surely make the cell structure irregular. Fine. And also due to this more influx or altered channel functions, ion channel function, there will be an increased neuronal firing and formation of epileptogenic foci, okay, which end up with the abnormal electrical discharge in the brain, and clinical manifestation is like jerking. You seen in the video, baby hand is jerking. Okay, or there is a staring, one constant state. Okay, the eye is staring, eyeball is staring. Fine. And if you not manage these conditions, then there will be a further inflammation and oxidative stress. Got it? Easy to understand? No problem. Fine. Now we can move to the management now. So for discussing the management, my friends, you have to understand that this neonatal seizure is preventable. It is something which you can manage by the drug as well as by certain, you can say, the other nursing, you can say the nursing support, or you can say some different supportive measures. So in context of managing the neonatal seizure, we have the two line of treatment. First is the first line of treatment, of course, and another one is the second line of treatment. In the first line of treatment, generally we are administrating one specific category of drug, and that is called as the anti-epileptic drug. Okay, and also called as the, write it down, the anti-epileptic drug is also called as anticonvulsant drugs. For competitive exam of point of view, this is very something which is really useful for you to understand. Now the first drug we have is a phenobarbital. Also we have the phenobarbital. Okay, this is a anti-epileptic drug. Basically these drugs make the excited neurons to calm. Okay, they make the excitable neurons to calm down. Are you getting my point? This is the mechanism of action, and it's a 20 to 40 mg per kg body weight. Okay, then we have the phenyltoin, 20 mg per kg. Then we have the phosphophenyltine and other sedatives like the benzodiazepines. One of the example is the lorazepam. Dose matters, so you have to remember the dose. Then we have the certain new latest drug which have the less toxicity, and that is called second line of treatment. We have the midazolam. Okay, initial dose is 0.15 to 0.15 mg per kg. Fine. Then we have the levetiracetam. Okay, 20 to 40 mg. Then we have the lignocaine. Lignocaine is good, but it have the high cardiac toxicity. So most of the time this lignocaine is not clinically used. Okay. Then we have the something supportive measures. We have to secure the airway. We have to assess the breathing pattern. Okay, and we have to make the good circulation, the good blood circulation. Then the corrective metabolic disturbance. If the patient is hypoglycemia, then we have to provide the, you can say, the insulin. Okay, we have to provide we have to make the patient have the good glucose level, so we'll administer the, you can say, glucose dips. Fine. Then if there will be a hypocalcemia, then we have to manage the calcium, you can say, amount in the patient. Then we also treat some of the, if the patient have the infection, then there will be a use of antibiotic regimen. Then if a patient have the intracranial hemorrhage, then we can use the certain, you can say, the clot buster like the streptokinase. Are you getting my points? So these are the certain management. Got it? So I hope you understood today's lecture. If this lecture is helping you, then of course like the channel, share our channel. Fine, like the video, share our channel, and also search the topic by searching, by adding our channel's name in last. Like you can take the example Alzheimer disease clinical care insight, Parkinson disease clinical care insight, Guillain-Barré syndrome microbiology clinical care insight. You can search anatomy clinical care insights like that. And apart from that, we have certain medical podcasts which is specifically meant for you to have the deeper interest in the learning of the medical science. Okay, the purpose is simple. Fine. We have this special guests like the PhD holders. Some of are the PhD holders. Some of are coming from the radiology department, and some of are coming from the pharmacological department. We have the Ayurvedic lectures. We have the homeopathic lectures and many more things. Fine. So thank you with having us. Bye. Have a nice day.